A challenge in the obstetric practice is, once we have identified that this particular mother is at a risk of preterm births, possibly because of her previous obstetric history, then the question comes, what would be the rational approach? So let's look at the management of women with previous preterm delivery or second trimester loss. So if you have women with more than 2 consecutive prior secondary trimester losses, or more than or equal to 3 early less than 34 weeks preterm births, then we can consider interventions such as either a transvaginal cerclage at 12 to 14 weeks and use of 17-OHPC caproate 250 milligrams intramuscularly weekly from 16 to 36 weeks of gestation. We can also consider giving them natural micronized progesterone at the dose of 300 to 400 milligrams per day, once in a day. And if you look at the options in the next pregnancy, if history indicated cerclage was not successful, that is, there was a preterm birth again at 33 weeks of gestation, then one may consider doing a trans-abdominal cerclage, or maybe using an arabine pessary, or maybe using a closer cervical imaging or surveillance on a transvaginal ultrasound. And these patients can be considered offering an 17-OHPC 250 milligrams intramuscularly weekly from 16 to 36 weeks of gestation, or giving daily 300 to 400 milligrams of natural micronized progesterone. Now, women with 1 prior second trimester loss or 1 or 2 preterm births, one can consider giving an hydroxyprogesterone caproate 250 milligrams intramuscularly weekly from 16 to 36 weeks of gestation, and a serial measurement of cervical length beginning at 14 to 16 weeks and ending at 24 weeks. If the cervical length is less than or equal to 25 mm, before 24 weeks, place a transvaginal cerclage. So this can be a sort of a categorization of how you can triage and manage the history of a previous spontaneous preterm birth. Progesterone supplementation has known to reduce the risk of preterm births by approximately 30%, and this is something that you must share with your patient because it's not a panacea, nor is the cervical cerclage a panacea. And therefore, other approaches of other supportive managements have to continue, and the patient has to be educated to reach the facility on time, because if at all she requires to be given tocolytics, they would be more effective after established preterm labor or birth ensues. So this particular effect of progesterone has been found in singleton pregnancies and those women who have had a history of spontaneous preterm births. So asking history for previous obstetric outcomes, whether they are single trimester losses or whether they are spontaneous preterm births where births have occurred before 33 weeks of gestation, are important because they can help us in appropriately triaging the patient and offering her correct education, information and treatment.